Welcome to the June edition of our Neuroscience Grand Rounds. For those online, if you would please make sure, we are recording this, and if you would please make sure in the comment section just to put your name and credentials so that we can give you appropriate credit for this activity. If you're in the room and joining us today, I know there might be some people coming in. Please make sure in the back in that corner there is a sign-in sheet. Please make sure that you sign in, even if you're not applying for CME or requesting CME, please make sure that you sign in so that you can get credit. Also, to receive your CME credits at the end, there will be a QR code as for the people in the room. It will either be on the screen or there is a version on paper in that back corner by the sign-in sheet. For those online, there is a link that they can put in the chat or QA box so that you can go in and fill out that SurveyMonkey link. So I want to make sure that I'm checking all the boxes for our wonderful CME team. I want to take this opportunity just very quickly to thank our CME audiovisual team that are helping with this today so that the recording is a wonderful recording that we can use for continuing education. And they've also done an amazing job to make sure that we have CME credits. So I have to disclose this information. There's no commercial support for today's activity. The speaker and planners have disclosed that there are no relevant financial relationships with any commercial interests. You will receive a SurveyMonkey link after today's activity. If you are viewing online, again, I have stated that it will be in the chat section. And again, if you are in the room, it is in the back. And if you have a question, please enter in the Q&A chat and we will ask your questions at the end of the presentation. So it is my pleasure to introduce Dr. Boghani. He is with our NGPG neurosurgery team. And this was a presentation that I was very excited that he presented, and he was very gracious and put this together. And so thank you so much, Dr. Boghani, for presenting here today. And thank you for the opportunity to allow this to be continuing education as well. Thank you.
Thank you, Lauren, for that fantastic introduction. Presentation we have today is nuts and bolts of intracranial hemorrhage. My name is Zain Boghani. I'm an attending neurosurgeon here with NGPG. I initially presented this back at the Neuroscience Symposium, probably on like 2 hours of sleep. I think the night before I had been on call and was actually managing an intracranial hemorrhage. And, you know, going back to this presentation, at that time, I was just trying to, run through the presentation. I was probably working on very limited sleep. But I thought about, what do I want from this presentation? What do I want to give the audience? And I think this presentation probably doesn't present the latest data or clinical trials or anything like that. I think what I want to present here is a framework and an introduction to intracranial hemorrhage, because your brain, the human body is an amazing piece of machinery, and your brain is really who you are. And so this is a very important pathology, and I think that understanding the brain helps me understand more about myself. So hopefully this presentation will give you kind of that introduction, and will give you some of the tools to go approach it afterwards. All right, so intracranial hemorrhage. What is it and why is it important? Intracranial hemorrhage is any bleeding within the intracranial vault, including the parenchyma and the surrounding meningeal spaces. The causes of intracranial hemorrhage are broad. There's several different reasons why you can get blood in your brain. There's multiple locations that can be involved, and sometimes, they can occur simultaneously. So a patient can have a subdural hematoma and a subarachnoid hemorrhage. And it is a significant cause of death and disability. And I think sometimes the esotericness of this pathology in the ER prevents us from really understanding it, and it's kind of shuttled off to neurology and neurosurgery. But I think that this is important for everyone, and especially our patients, because it really can change your life. And a lot of the times with intracranial hemorrhage, the patient is actually very much disabled, and it can really change them as a human. Where we come in is that we can reduce the amount of secondary injury. And in order for us to do that, we really need to understand the pathology. So why is intracranial hemorrhage so important to understand and manage quickly? It's because of secondary injury. So secondary injury is injury that occurs after the initial insult. And this is dictated by this doctrine, the Monroe-Kelly doctrine. The Monroe-Kelly doctrine is the concept that the sum of the intracranial contents has to remain stable. So inside the skull, there's going to be brain, spinal fluid, and blood. There's a very specific amount of each of these things that's there. So any change in one is going to cause either a change in the amount of the other or an increase in intracranial pressure. And intracranial pressure causes secondary injury. This schematic shows that about 10% is cerebrospinal fluid, 10% is your blood volume, and 80% is your brain parenchyma. The skull is a closed space, and we're kind of over that. And so what kind of makes up this box, right? The box that is your skull. What are the things that kind of make it up? And understanding intracranial hemorrhage relies on a basic understanding of anatomy, of neuroanatomy. And so kind of working from inside out, because the brain is the most important thing. So if we work from inside out, there's multiple layers that cover the brain. The brain is covered by the meninges, which is a complex structure. It's a 3-layer structure that covers the brain. It provides a supportive architecture for the blood vessels. It supplies nutrients and removes waste. There's distinct compartments which, along with the cerebrospinal fluid itself, protect the brain from mechanical injury. So if you look at this image, we're starting from the brain out here. This schematic kind of shows the meninges, which are in green, okay? And then obviously the skull, which the skull, like any other bone, has a complex structure. So, it has a cortical layer, cancellous layer, and another cortical layer, and then the scalp. So this has obviously been evolved over, hundreds of thousands of years. And the reason why that this is such a robust system is because it is perfectly designed to protect the brain. This is kind of a enlarged view, so kind of a little bit nuts and bolts again. So brain parenchyma, the first layer that's on the brain parenchyma is going to be the pia mater, very fine layer that covers the brain parenchyma. Then the next layer is going to be your arachnoid mater, which is kind of like a spidery layer, which has the blood vessels, the small blood vessels that supply blood to the brain and have the veins as well to drain blood and take away waste products. And then on top of the arachnoid mater is the dura mater, which is a tough layer which has the dural venous sinuses. So it's involved in the venous drainage of the brain. And then, of course, the skull and the scalp. This is just a enlarged view of exactly what I've said on the last slide. Here, I think the schematics never really do the brain justice. It never does anatomy any justice. So this image kind of shows how closely the brain is interlinked with all of the structures that are there to support it. So, we can see the dural leaflets right here. And the dura is not a simple structure. The dura has multiple layers. It has folds. It kind of, and we can spend, months, years talking about neuroanatomy. The goal of it is not to overwhelm you, but just kind of to show you how, amazing this machinery is. The the dura and the meninges also have the blood vessels. So the blood vessels are all in the subarachnoid space, and it's a very complicated structure. But what I want to demonstrate here is that your brain usually is about 3 pounds, and for a person like me who's 185 pounds, is probably just about 1.5% of my actual weight. But the brain receives 20% of your cardiac output, and so this is a very complicated system, and so the anatomy is so critical to understand the pathology. This is a lateral image of the brain, and so here we're kind of just demonstrating some basic anatomy. So the brain has 4 lobes. So frontal lobe, parietal lobe, occipital lobe, temporal lobe. It has 2 hemispheres, and it is connected to the rest of the body via the brainstem, which is behind the cerebellum, and the cerebellum is also a structure, a much older structure, which is involved with movement and coordination. Here's more of a diagram. Again, this is a mid-sagittal cut, and we're trying to demonstrate that the anatomy is complex and kind of working from outside in. All these structures are very connected, interconnected, and the anatomy is very important to understand intracranial hemorrhage, because where the hemorrhage is really dictates what we may do. How large the hemorrhage is will dictate what we do. And so it is so critical to understand the neuroanatomy. Of course, I can't explain all of it in the next 45 minutes, but I encourage people to go out and take a look at it. So breaking down intracranial hemorrhage, the basics, okay? The most important thing about intracranial hemorrhage really can be broken down into these 3 questions. What is the story? How did this happen? Is it a traumatic etiology? Is it an atraumatic etiology? So the story of how the patient got there is so important. And sometimes the patient's not able to tell us the story. So we have to conjecture. So there's some detective work that's involved with managing intracranial hemorrhage. The next thing is that where is this hemorrhage located? Is this hemorrhage a supratentorial hemorrhage? Is this above the tentorium? Is it in the infratentorial compartment, below the tentorium? Where is it located? Because that will have major implications on how much space there is because the compartment up here, up top, the supratentorial compartment above the tentorium, there's much more volume there. So it has a little bit more of an ability to tolerate hemorrhage, whereas intracranial hemorrhage in the infratentorial compartment, the brain has much less tolerance because it's a much smaller space. And where is the hemorrhage in relation to the meninges? So I think this kind of feeds into the location component. But if we can understand where it is in relation to the meninges, we can have a better idea of how to manage the hemorrhage. And also, it will kind of give us a framework. So it's almost like we're looking at intracranial hemorrhage, but there's all these other subsets. So if we understand where it is in relation to the meninges, because that's how we describe it in our medical literature and how we speak to each other as medical professionals, we usually describe it really where it is in relation to the meninges. So, and I'm going to go over these 4 subsets of intracranial hemorrhage. So we're going to go over just some cases. We're just going to run through some cases of epidural hemorrhage, epidural hematoma, subarachnoid hemorrhage, interparenchymal hemorrhage, and intraventricular hemorrhage. So epidural hematoma. The bleeding is going to be in between the skull and the outer layer of the meninges. The most common cause of this is going to be a traumatic hemorrhage. Atraumatic epidural hematomas could be due to a variety of things. They're less common, but vascular malformations, coagulopathies, tumors. There's a wide, long list, but the most common thing is going to be a traumatic epidural hematoma. So here is a case that I'm going to present of epidural hematoma. This patient comes into the ER, has been struck in the head with a baseball. Initial loss of consciousness followed by complete recovery, kind of went out there for a few minutes, but then he started to deteriorate again and had complete loss of consciousness. This prompted EMS to be called, and he was intubated in the field because he wasn't protecting his airway. He was brought to the ER. He presents now with a GCS of 3. So highlighting here the story is so important. We know that the patient has suffered a trauma. He suffered a trauma to his head. This is the CT scan. This is a axial, non-contrasted image. What we see here is that there is a biconvex, hematoma that's present on the left side. There's significant midline shift. So these structures right here, the ventricles, are shifted away from their midline position. We can see that there's overall fullness because we don't see the sulci of the brain that we usually see on CT scan. So this is obviously an emergency situation. So what do we do? Okay, management of all things always starts with airway, breathing, and circulation. After that, once we've addressed those key factors, then we move in to disability, which really is, I think, the neurology of things. So once you've addressed the ABCs, you follow that with figuring out what the story is, examining the patient, which is a quick neurological exam. And, in the modern era, the way that we manage this is with imaging. So a CT scan of the brain, and frequently, here, obviously, if there's a trauma, we're going to get a CT scan of the whole body. We're going to get a pan scan. But if that was not to happen, at the minimum, we want to get a CT of the brain and cervical spine, because patients who have head trauma can present also with spine trauma. And it is very critical to know about any type of spine trauma, because it's going to make a difference when we take the patient to the operating room, how we manage them, how we move them. So that's going to be your next step. While we're also doing this, we're kind of doing things simultaneously. So we're going to call neurosurgery. In the ER, we're going to start the basics of intracranial pressure management, increased intracranial pressure management. So we're going to raise the head in bed. We're going to ensure that the collar's not too tight. We're going to start hyperosmolar therapy, either with hypertonic saline or mannitol, depending on what your institution is. We're going to call the neuro ICU. And then we're going to figure out, is this operative or non-operative? Because obviously, I presented a case where the patient had a head trauma and, deteriorated very quickly. So it's likely going to be an operative situation. But there can be epidural hematomas, which are smaller, and the patient isn't taken to the operating room. And that's, that really comes to the fine points of management of intracranial hemorrhage. But the basics of it is kind of all the same, So these are the things that we're doing when we're starting the management of this pathology. Some pearls here. Usually an epidural hematoma is due to a skull fracture, which involves one of the arteries that's in the actual dura mater, the middle meningeal artery. The reason why it forms a biconvex kind of image or bleeding is because of the suture. So the dura also kind of attaches into the skull. And so it's going to form this biconvex type of hematoma. The length of time to an operation in patients where a surgery is indicated is absolutely critical in avoiding death and disability. This has to be managed quickly, and it can make the biggest difference. I myself had a case of a very large epidural hematoma from a patient who had had an ATV accident. Came in, GCS of 3. The patient had probably one of the largest epidural hematomas that I've ever seen in my life. It was about 4 or 5 centimeters thick, and we quickly took the patient to the operating room, decompressed him, and he made a full recovery. So we are so critical. I mean, there's a primary injury that's happened already, but our job is to expedite the care of this patient to avoid that secondary injury. This is just kind of a picture of what it looks like in the operating room. So here, what we're seeing is basically the patient has had a linear incision. The scalp is retracted back from the self-retaining retractors. A bone flap has already been raised, so we've already drilled out a large piece of bone, and we can see immediately there's this jelly like substance, this is the epidural hematoma. It's a large blood clot that's pushing on the brain, and so we'll irrigate and suction this out. We'll coagulate whatever the sources of bleeding are. We're going to tack up the dura, and then we're going to close this up nicely and manage the patient in the ICU. Okay. So moving on to subdural hematoma. Okay, this is an extremely common form of intracranial hemorrhage. This hemorrhage essentially occurs below the skull and below the outer layer of the dura mater, but above the arachnoid, above the pia and the arachnoid mater. The most common cause of subdural hematoma is trauma, but there's a variety of atraumatic causes, which again lends to the fact that we need to listen to the story. But a tumor can cause a subdural hematoma, vascular malformation. It could be hematologic with a patient who has low platelets or is on blood thinners. There's several different things. A key distinction with subdural hematoma is figuring out whether this is an acute versus chronic subdural hematoma. And you could say, well, every chronic subdural hematoma started as an acute subdural hematoma. But really, I think what we're trying to get to is that if the patient has suffered a very high mechanism type of injury and is presenting with low GCS and has an acute subdural hematoma, the injury is probably going to be to a arterial source rather than a chronic subdural hematoma in an older patient who has kind of an insidious onset, which could be from a bridging vein. Let's see. The way to kind of distinguish this as a story, and also the way that we can distinguish this is by looking at the CT scan and aging the blood on the CT scan. So here is kind of here are 3 CT scans which show a left-sided subdural hematoma. And it's the same blood clot that we're showing here. So we see that, we see this kind of banana-shaped hematoma right here. And we could see the distinction between, this is the parenchyma of the brain. We see the interface between the blood clot and the brain. And here, what we see is that a month later, the blood clot actually looks very similar to the brain. And sometimes this can fool you, right? This could be like, oh, you don't see it. But if you look closely at the CT scan, again, we can kind of see how this is forming kind of over the brain, and that there is subdural hematoma. You also see that you don't see sulci here, but you do see sulci right here, which is away from the hematoma. You see the spinal fluid, cerebrospinal fluid right here. You don't see the cerebrospinal fluid right here, and then you see it again here. So, this can trick you. This can be quite confusing. And then, if you follow this out to a chronic subdural hematoma, it becomes hypodense. So then it becomes darker than the brain on CT scan. And this is due to the aging and breakdown of blood. And it also kind of changes in its consistency. So initially, it's kind of more like a jelly right here. And then here, we call this like a motor oil chronic subdural hematoma, because when we make the burr hole to evacuate this, it kind of comes out like motor oil. So here's our case, okay? So this is an 82-year-old woman. She's on aspirin and Plavix, and she presents with a 1-week history of confusion. She's had some mild worsening of her speech and difficulty finding words. She's also having some right-sided weakness. There's no history of trauma, although if you ask her some more, she bumped her head some weeks back on a cupboard, and that's essentially what's happened. She doesn't have any major trauma. Looking at this history, your alarm bell should come off and you go on, because the patient has a history of using aspirin Plavix. She has had this kind of insidious onset. She has a little bit of weakness, so she has a lateralizing sign. She also has the difficulty with speech. For the vast majority of people, our left side is the dominant side. So I suspect, even without the CT scan, from just this story, that this patient may have perhaps a left-sided pathology. And so here's her CT scan. So this is an axial non-contrast CT scan of the brain. And what this is showing is a large acute on chronic subdural hematoma. You can again see it right here. And, kind of, if you look at the outline of it right there, that's the brain hematoma interface. You can see that there's some midline shift. You could also see that, the patient has nice sulci on the right side, and you can see how the sulci are kind of compressed on the left side. This could potentially explain why she's weak and why she's having difficulty with her speech. And the management of, subdural hematoma kind of, again, varies. And those, the management of it is now advanced a significant amount. We, obviously do the burr holes to evacuate it quickly, but now with endovascular treatments, we also have MMA embolization. So we have lots of different tools to manage these pathologies. Okay, subarachnoid hemorrhage. So this type of bleeding occurs between the pia mater, which is a layer just above the brain, and the arachnoid mater. That's that spidery layer that kind of has all the blood vessels invested in it. The most important distinction that's necessary with subarachnoid hemorrhage is figuring out, is this from an aneurysm or is this non-aneurysmal? It will have major implications on the management. The most common cause of subarachnoid hemorrhage is, again, trauma, but there's a subset of aneurysmal subarachnoid hemorrhage, which has a more complicated and the implications are pretty major if there's an aneurysm ruptured in someone's brain, because possibility of rehemorrhage and how that can cause death and disability. So the causes of non-aneurysmal subarachnoid hemorrhage, trauma, but there's many different atraumatic causes. This list is extensive. We talk about each of these individually, but we just want, when we're thinking about subarachnoid hemorrhage, we should just start with aneurysmal versus non-aneurysmal. The story and the imaging, and the imaging is really a conduit for the anatomy, is really very important in distinguishing aneurysmal versus non-aneurysmal subarachnoid hemorrhage. there's some key words, the thunderclap headache, the worst headache of life, is kind of the classic presentation of aneurysmal subarachnoid hemorrhage. There are certain risk factors that we look for. Hypertension, age greater than 60, history of an aneurysm, drug use, estrogen deficiency, polycystic kidney disease. And then the imaging studies come in, and the CT scan, which is without any contrast, will have blood that's located more at the base of the brain in the cisterns, where the large blood vessels, where an aneurysm would occur. That's where the blood will be located. And the definitive studies to find out if the patient has an aneurysm is an angiogram. We also do CT angiograms in the ER because that's a much quicker, less invasive way of sorting out if the patient has an aneurysm. So we'll do a case. This is a 52-year-old woman. She presents with worst headache of life and multiple episodes of vomiting. She's a little bit confused. She has a history of high blood pressure, coronary artery disease. She smokes a pack of cigarettes a day. She has some recent methamphetamine use. And so she is just an absolute, absolutely has many of the risk factors for subarachnoid hemorrhage. And this is the CT scan, right? So we addressed our ABCs, we talked to the patient, we got our history, and now we're into the imaging. The imaging is trying to understand the anatomy. And so we have CT scans, we have an axial on the left, we have a coronal on the right, and what we're looking at here is the suprasellar cistern. So we see blood, blood will appear white in the suprasellar cistern, and in the sylvian fissure, we see that there's an increased amount of blood right here. So whenever we see this type of configuration on a CT scan, the idea that, or the thought that this patient may have an aneurysm which is ruptured comes to mind. And this coronal kind of shows, so, if this is the top of the head, this is the base of the skull, you can kind of see the bleeding has occurred closer to the base of the skull. And this is where all of the major blood vessels of the brain kind of enter. They enter from the base of the skull, obviously. So in the ER, we make that astute determination that the blood is in the suprasellar cistern. There's more to the right than the left. The patient has all these risk factors, and so we find that there's a ruptured aneurysm on the right side, and we can see, that there's a middle cerebral artery aneurysm at the bifurcation of the MCA, the middle cerebral artery. The initial management, the initial management is the obvious ABCs, and but now that we have kind of determined that this is an aneurysm that's ruptured, we have to do this subset. Is we need to make sure that this aneurysm is treated, because rebleeding of the aneurysm will likely lead to major disability and death. There's also other factors that come in. So the patients who have intracranial hemorrhage are at very high risk of hydrocephalus. So that's always in our mind. That's increased buildup of cerebrospinal fluid due to the pathways being obstructed for the drainage of the cerebrospinal fluid. And there's also this entity known as vasospasm. So blood, when it's outside of the compartment that it's supposed to be in, the blood vessels, is extremely caustic and inflammatory. And what it does is that it causes blood vessels in other parts of the brain to constrict. And this causes secondary injury, because it causes strokes in the brain. So in the ER, we started with the ABCs. We're going to keep our blood pressure less than 120. to avoid rehemorrhage, we'll start anti-epileptic medication, and we'll start nimodipine to avoid vasospasm. We'll consult neurosurgery, neuro-IR, to evaluate the aneurysm and hydrocephalus, and then we'll figure out a way to manage this aneurysm. And there's surgery versus endovascular management. This is a image from the operating room. The anatomy here is perhaps the most amazing and complex and beautiful anatomy. But what this picture shows is a image under the microscope, and we're looking at the right side. So this is the right optic nerve right here. Actually, no, sorry, this is the left optic nerve. You can see the right optic nerve is going to be tucked underneath right here. And what we see here is the aneurysm. This is an internal carotid artery aneurysm. So there's the aneurysm is being clipped right here. So, and then this is the frontal lobe, this is the temporal lobe. So moving on to intraparenchymal hemorrhage. This hemorrhage is located within the parenchyma of the brain. Determining whether the hemorrhage is traumatic versus atraumatic, absolutely one of the most critical things here. There's multiple causes of atraumatic intraparenchymal hemorrhage. Hypertension, amyloid angiopathy, vascular malformations, drugs, tumors are all kind of the top 5 causes of atraumatic intraparenchymal hemorrhage. There's some less common causes. One of the most common ones that we deal with is hypertensive intraparenchymal hemorrhage. We see this in the ER all the time. And so this is caused by a rupture of a microaneurysm, a Charcot-Bouchard microaneurysm, which is within the parenchyma of the brain. There's some certain sites that are very common, and that will prompt us to think, okay, this must be due to high blood pressure. And there's some factors that we consider because a lot of patients do present with this, and the management can vary from just supportive care all the way up to surgery. And so we need to know the size, location, where it is in relation to the ventricles, because if the blood blocks the drainage of cerebrospinal fluid, we're going to have hydrocephalus, and so that's that secondary injury that we want to prevent. And then the age and the GCS of the patient. This is a case that this patient is a 60-year-old man. He has hypertension, he smokes cigarettes, presents with a facial droop and left-sided weakness and cannot move his left side. He's hemiplegic. Stroke alert is called. The patient has a CT scan of his brain. CT scan demonstrates a large hemorrhage in his thalamus with intraventricular extension. What are the next steps? Go through his airway, breathing, circulation. We go to disability, get a neurological exam, obtain a CT scan of his head, and based on the findings of the CT scan of his head, consult neurosurgery and the neuro-ICU. We want to prevent secondary causes of injury, so preventing hydrocephalus and controlling intracranial pressure is going to be absolutely critical. So here's a CT scan. This is an axial CT scan of the brain. What we can see is there is a large hemorrhage right here. It's in the basal ganglia, and then there's extension into the ventricles. So this is an example of a hypertensive intraparenchymal hemorrhage with intraventricular extension. But the hemorrhage obviously could be different, and that would lead to a different management protocol. The hemorrhage could be much larger. It could present in this hemorrhage, in this CT scan, we could see that the patient has extensive hydrocephalus. This CT scan is perhaps demonstrating a hemorrhage from a tumor. This CT scan is demonstrating and arteriovenous malformation, which has caused the hemorrhage. And then over here, this CT scan is demonstrating a hypertensive hemorrhage, but in the infratentorial space in the cerebellum. So the management of these 5 different patients is going to be different, and we need to know what the story is. We need to understand the anatomy. We need to get the appropriate imaging, which will act as a conduit for us to understand the anatomy, and then employ the appropriate management to prevent secondary injury. So just kind of in conclusion, it's critical to always start with the airway, breathing, and circulation. Intracranial hemorrhage is very esoteric, but trying to break it down into simple questions and categorizing it based on where the hemorrhage is occurring in relation to the meninges will help us understand what we need to do next. And lastly, we need to think about secondary injury. So hydrocephalus, repeat hemorrhage, increased intracranial pressure are all things that are going to happen after the patient gets to the hospital. And those are where we, the healthcare providers, the healthcare team, are really important. And this is where we can make our difference. Okay, thank you so much for having me give this talk. I really appreciate your time.